Neal, you're in Myrtle Beach, community size, what, 100,000? Smaller than that?
Well, it's one of these crazy communities. Depending upon if the tourist data, it could be 12 million people, but I think the permanent population's a couple 100,000.
And you've got 13 in the group now?
We're 13, and we now have 4 physician extenders, 3 PAs and 1 NP, and they've worked out, remarkably well, as Dave is saying. You said earlier, we're aging manpower issues, aging urology population. By the way, it's not just urologists, medical oncologists there's a shortage of them as well, and they're also an aging specialty. And we have an aging population, so there's more and more patients that have to be taken care of, and people are living longer through better cardiovascular health. And I think physician extenders help with that throughput. Being a little contrarian about it, there is a little bit of pushback on some of the physician extenders. Well, should they be allowed to do certain procedures? Should they be allowed to do cystoscopy? And I think we have to, have a healthy debate about that. But there's no doubt that the American public is getting used to the fact that it's not always going to be readily accessible to get a physician all the time. And as Dave's saying, some of most, I think, of the physician extenders with proper training really do a very good job, and they manage that throughput. So we have 4 now, and I suspect we'll probably, we've talked about most likely going to 6 or 8 in the next few years with managing clinics of specialization, and we'll talk about it, and Paul will address it, a bone health clinic, prostate cancer, male health clinic. I think in your center, Raul, you have a female sexual dysfunction clinic, and maybe there's pelvic pain clinics and complicated stone clinics that physician extenders, rather than one of your full-time physician partners, can also take care of.
No, I think that's clearly an issue, and I think how we utilize them within the practice, whether it's going to be as a general practitioner versus subspecialization, really it probably varies from market to market, state to state. Mark, you and I had this discussion last September at the State Society Network. So you've got 5 extenders, and you're in where west of you could go hundreds of miles and never find a urologist.
Well, I think that brings up a good point. I think that in a large practice or an academic practice, I think that they're very useful to facilitate your subspecialization or your specialty clinics. And they're very good at helping with education, which is very time-consuming, and dealing with chronic illnesses, changing of suprapubic catheters or other chronic illnesses that are associated with urology. But in small communities, they might fill a valid role in supplying some of the urologic care there. In a small community in western Kansas where there's no urologist for many miles, they might be supervised to help out in the emergency room for urinary clot retention or stricture dilation or something where you can't get a catheter in, where these patients normally would have to be shipped, maybe even helicoptered into another community. I think it is a controversial issue in the country, though, because like you alluded to earlier, Raul, state to state, these are regulated. Many are pushing for independent practices and independence. And I think as the nurse practitioners and sometimes the PAs push for independent practice, then we have to be careful, because at that point then we lose our supervision and our quality assessment control then becomes looser, and then who's supervising them? In our settings, we're supervising them, and I think they work great. And as long as it continues that road, I think that they're going to fulfill a huge role and an important one. But with the independence, I think we have to be a little careful on how they're trained and who trains them, and then who does their continuing education and their oversight.
Paul, anything to add to?
I think the training is the crux. The training is a big issue. I mean, the nurse practitioner does not have a urology residency fellowship. I mean, you've got a gal or a guy who's got a bachelor's degree and spends 2 years in NP school and a short time and they're out. I mean, they have less time than a family practitioner, and yet they want to suddenly have a specialty role. I mean, I guess you're saying my 6 years in urology residency, I was just slow. I was a slow learner. My goodness, they're trying to accumulate all the data overnight, or you're going to treat them in 6 weeks. So it's tough to get them, and I think the challenge for us is to educate them and to get them to do the things we want them to do versus treating them like they're an intern or a resident. I mean, the resident, at least they've got a little more years behind them, and I think it's a real challenge for them because they come in pretty much trained as a family practitioner by and large. They don't come in trained as a urological nurse practitioner.
I think that's true, but I've had the opportunity to have 3 green nurse practitioners come and work with me in the last 5 years. And all 3 of them, the training portion of it was pretty minimal. They follow me around, they follow my partners around, they go work with another nurse practitioner, and they're really up to speed in a very short period of time. We all learn every day by seeing patients and things like that. And the key is when they don't know something that they need, don't feel bad about asking you, what should I do with this? And to me, that has not been an issue. I think I think it's kind of a moot point about cystoscopies. It takes a lot of training to do cystoscopies. Some OB-GYN people or gynecologists do it now. I think even more important is, what about prostate biopsies, and what about things like that we do every day that you don't, they're not that hard. Come on. And reading ultrasounds and things like that is not that difficult. So, in our place, it's transitioning to that. They're going to be starting to do that, but there's a little pushback.
No, I think you're right. I think this is a big topic, and it will be ongoing. Being in Nashville, I remember talking, this is very tangential, but I think it's a great analogy. I was talking to a friend of mine in the music industry, and 10 years ago, 12 years ago, he kept wanting people to buy more compact discs, buy more CDs, as he was fighting the whole concept of digital music and things like that. And so I asked him a couple of years ago, I said, if you knew then what you know now, what would you have done different? And he said, I would have figured out a way to embrace that technology as opposed to fight it, because now I'm behind. So I think we probably have to come from the adage, extenders are here to stay. We're going to have to figure out how to embrace them, how to utilize them. But again, Mark, I think the whole concept is to somehow make sure that we sort of maintain control of their scope of practice.